Hi, I am María del Mar Alvarez-Torres, researcher from the Biomedical Data Science Laboratory at Universitat Politécnica de Valencia in Spain, and I'm going to present a study about the lack of benefit of temozolomide for MGMT methylated patients with high vascular glioblastomas. We know that glioblastoma patients have a poor prognosis with a median overall survival of 12 to 15 months from diagnosis, and this devastating survival rate is still being despite the complete treatment provided to patients. It's the STOOP treatment, which includes the surgery of the tumor, also radiotherapy and chemotherapy with concomitant temozolomide, and also adjuvant temozolomide. Due to the high interpatient heterogeneity, the same treatment for all patients with glioblastoma has been demonstrated as ineffective. So different modifications of the STOOP treatment have been analyzed in previous studies, including the modification of the number of cycles of adjuvant temozolomide, increasing the standard number, that is 6. However, there aren't any robust results in this sense, and a phase 2 randomized trial which analyzed the benefit of increasing the adjuvant temozolomide cycles from 6 to 12 conclude that their findings suggest that continuing with more than 6 cycles did not confer a benefit in patients, both in progression-free survival and overall survival. Considering that each tumor and each patient is different and has a different survival, it's important to consider related factors like MGMT methylation and tumor vascularity to provide a more personalized treatment. As we know, these two factors are related with longer survivals in glioblastoma patients. Therefore, to analyze this possible combined effect of MGMT methylation and vascularity in survival, we include a cohort with 123 patients with glioblastoma, and we stratified it into groups according to the methylation of the MGMT. 67 patients presented methylated MGMT and 56 patients were with unmethylated MGMT. In addition, we wanted to consider the tumor vascularity to analyze the possible effect of the MGMT methylation in survival, and for that we used the methodology oncohabitats. With these slides, we represent the oncohabitat process that, using the morphological MRIs, T1, T1C, T2, and FLAIR, and also the DSC perfusion dynamics, we can get the 4 vascular habitats included at the tumor and the edema. The high angiogenic tumor in red, the yellow is the low angiogenic tumor, and also at the edema, we can differentiate between the infiltrated peripheral edema in green and the vasogenic peripheral edema in blue. In addition, we can calculate different biomarkers in each one of these habitats, like the RCVV or the RCVF. For this study, and to stratify the patients in groups according to the tumor vascularity, we used the relative cerebral blood volume, the RCVV, calculated at the HAT habitat, the high angiogenic tumor habitat. And we calculate the median RCVV for all the cohort and divide this population in two according to the threshold 9.1 of the RCVV. And patients with a lower RCVV are included in the moderate vascularity group, and patients with higher RCVV are included in the high vascularity group. According to that, and considering these two factors, the MGMT methylation and also the tumor vascularity, we can differentiate 4 groups. At the left, we can see the Kaplan-Meier curves for the moderate vascular groups, and in blue is marked the methylated MGMT group, and in red the unmethylated MGMT group. We can see that there is a clear difference in survival, and with a median difference survival of 174 days. However, at the right, we can see that the high vascular group are also stratified according to the MGMT methylation status, and we can see that the Kaplan-Meier curves are not significantly different. So for patients with high vascular tumors, it's not relevant for survival, the MGMT methylation. And finally, I want to show some preliminary results about the survival differences according to the MGMT methylation and the tumor vascularity, but also considering the number of cycles of adjuvant temozolomide provided to patients. These results are made with retrospective data, and they have to be considered with caution, but we can see some differences. For example, if we see the methylated MGMT and moderate vascularity group that is in blue, we can see that provided more than 6 cycles, from 7 to 12, could be positive for the patients in terms of survival. However, patients with methylated MGMT but with high vascularity, that are the group in yellow, we can see that provided more than 6 cycles, doesn't provide a benefit in survival. So this is only a preliminary study to analyze the modifications of the cycles of temozolomide according to these both factors, the MGMT methylation and also the tumor vascularity. And this is all. Thank you for your attention.